Okay, so today we are going to discuss the perforated peptic ulcer disease. A 50-year-old male smoker with a long history of NSAIDs used for osteoarthritis presented to A&E with acute onset of abdominal pain in the epicystem. On examination, there was abdominal tenderness, rigidity, and infrequent bowel sounds. So, what's the most likely diagnosis? So, it's perforated gastric ulcer or duodenal ulcer. Now, comment on the X-ray. So, the X-ray shows this is abdominal X-ray with both hemidiaphragms, and the X-ray shows air under diaphragm on the left side, right side, and the left, and yes, so moderate amount of subdiaphragmatic air on the right side, and air under diaphragm. So this is viscous perforation, either peptic ulcer disease, gastric perforation, or duodenal ulcer perforation. So differential perforated peptic ulcer disease, perforated diverticulitis, subphrenic abscess, iatrogenic infection with gas-forming organisms, and ischemic bowel disease and necrotizing enterocolitis. Sometimes after laparotomy there can be air under diaphragm, so it will be it should be taken into consideration. As sometimes there is another syndrome which is called Chilaiditi syndrome, in which the colon comes here, so it has air, so sometimes it looks like air under diaphragm. So Chilaiditi syndrome. What are the risk factors for perforation? NSAIDs, H. pylori, steroids, previous peptic ulcer malignancy, smoking, and the yes, so steroids as well. So what are the risk factors for perforation, particularly in this case? So NSAID and H. pylori. How can NSAIDs cause peptic ulceration? So topical irritant effect of these drugs on epithelium, impairment of the barrier properties of the mucosa, suppression of gastric prostaglandin synthesis, inhibition of cyclooxygenase type 1, reduction of gastric mucosal blood flow. So this will lead to sloughing, necrosis, interference with the repair of superficial injury. So what are the management options available for this patient? This is urgent category of NCBOD classification according to CCRIS protocol. A mental page repair. First you have to do ABC, 2 wide bore cannula, ABCDE 2 wide bore cannula, and resuscitation. And in mental page or Graham page, good peritoneal toilet, intra-abdominal drain. In perforated gastric ulcers, we will check biopsy to rule out malignancy, not in duodenal ulcers. Which post-operative medication would you suggest in this patient? So long-term PPI. What is the mechanism of action of PPI? So they irreversibly block the hydrogen potassium ATPase. So on gastric parietal cells and blocks the secretion of hydrogen ions. So when there is no hydrogen ion, so there will be no HCl. What are the actions of HCl? So HCl activate pepsinogen into pepsin, which help in proteolysis, protein digestion or peptide digestion, and it is antimicrobial, stimulates small intestine mucosa to release CCK, cholecystokinin and secretin, promotes absorption of calcium and iron in the small intestine. So usually iron is in the ferric form, so it converts it into Fe+2 ferrous form, so it can be absorbed. This form cannot be absorbed, so that's why. Maintains optimum pH for action of pepsin. So pepsin only acts in acidic environment, so it also gives the best pH, optimum pH for its function. So what are the phases of HCl secretion? So we have cephalic phase, gastric phase, and intestine phase. Cephalic phase, smell, taste of food. 30% of the acid produced, vagal cholinergic stimulation causing secretion of HCl, and gastric release from the G cells. So this is cephalic phase. Gastric phase, distension of stomach due to food, 60% acid produced, stomach distension, low pH, low hydrogen, peptides, gases, gastrin release. So that's why. Intestine phase, food in the duodenum, 10% acid produced, high acidity, distension, hypertonic solution in the duodenum, inhibits gastric acid secretion through enterogastron, CCK, secretin, and neural reflexes. So these are the three phases for gastric acid secretion. So this is NCEPUT, the National Confidential Inquiry into Patient Outcome and Death Intervention. So there are four categories. Immediate category, we have the immediate category. So these are aortic aortic rupture, abdominal aortic aneurysm rupture, and are large vessel rupture, inferior vena cava rupture. So these should be done within minutes. The resuscitation and operative or intervention should go side by side. The next is urgent. It is like peptic ulcer disease. So the above case is urgent. So this this should be operated within hours. You can have time for resuscitation and expedited. These are usually uh, patients which are like tendon and nerve injury stable, non-septic patients for wide range of surgical procedure, retinal detachment. So these patients can have time. They can be done within days of decision. So they have much time than urgent one. And elective is in your choice. Whenever you want to operate, you can operate. For example, cholecystectomy and hernia. Okay, so this is the chart for the classification of surgery. This should be done ASAP. Urgent should be done within 48 to 78 hours. Delayed for weeks, can be delayed for weeks. And planned or booked in advance, these can be delayed for months and years.